Hi guys, the topic for today is the granulomatous disease of the nose. So what is the definition of granuloma? A granuloma consists of a macrophages, epithelioid cells and the multinucleated giant cells. It can be seen in infective, inflammatory and neoplastic condition of the nose and sinuses. So what are the infective conditions like tuberculosis, leprosy, rhinoscleroma, syphilis, actinomycosis, aspergillus, zygomycosis, rhinosporidiosis, blastomycosis, histoplasmosis, sporotrichosis, coccidiomycosis and leishmaniasis. These are the infective conditions. So what are the inflammatory conditions like Wagner's granulomatosis, Churg-Strauss syndrome, cholesterol granuloma, eosinophilic granuloma, and the neoplastic conditions like the T-cell lymphoma, midline lethal granuloma. So let us talk about the rhinoscleroma. What is rhinoscleroma? It is caused by the gram-negative bacillus Klebsiella rhinoscleromatis or the fish bacillus. It is endemic in the several parts of the world. North India is affected more than the South India. Male is to female ratio is approximately equal. It affects the nose, nasopharynx, oropharynx, larynx, trachea and the bronchi. Well, the unknown mode of infection is there. See, here's a diagram. You can see how it looks, rhinoscleroma. There are three stages: the atrophic, granulomatous and interstitial. So atrophic, foul smelling, purulent nasal discharge with crusting. It resembles the atrophic rhinitis. Granulomatous, nodule formation occurs with subdermal infiltration of a lower nose and upper lip, giving a woody feel. So MCQ, it gives a woody feel, painless and non-ulcerative. Then the cicatricial, the stenosis of the nares, distortion of the lip, adhesions in nose, subglottic stenosis and respiratory distress. So here we can see the biopsy shows the mucormycosis cells, the macrophages with the bacteria present, the Russell bodies, eosinophilic inclusion bodies, along with the plasma cells and the lymphocytes and eosinophils. So what is the MCQ for the rhinoscleroma? The mucormycosis cells and the Russell body. Mucormycosis cells, what are these? These are macrophages with the bacteria, and the Russell bodies, it is eosinophilic inclusion bodies. Now comes the treatment. Streptomycin 1 gram per day and tetracycline 2 grams per day for 4 to 6 weeks. Repeated if required after a month. Steroids added to reduce the fibrosis. Rifampicin with sulfamethoxazole and trimethoprim and ciprofloxacin oral therapy given nowadays for the good results. Elevate 2% acrylflavin for 8 weeks. Treatment stopped if two consecutive cultures from biopsy are negative, and surgery required to maintain the airway and treat the nasal deformity. Irradiation of total dose of 3000 to 3500 gauges over 3 weeks, but less likely to be needed. Now comes an infective is syphilis. Well, the nasal syphilis is of two types. It's acquired and the congenital. So first we will talk about the acquired. Acquired, it's a primary, is rare and manifests as a primary canker of the vestibule of the nose. Secondary occurs as a simple rhinitis with crusting, recognized by the mucus patches in the pharynx, skin rash, fever and the generalized lymphadenitis. So what we will see? We will see the mucus patches in the pharynx, skin rash, fever and generalized lymphadenitis. In the tertiary phase, the gumma over the nasal septum, the gumma over the nasal septum is seen with the offensive nasal discharge. Septal deformity causes the saddle nose. So here we can see the tertiary syphilis with an ulcerated gumma and the cicatrization of the bony nasal dorsum. So now comes the congenital. In the first 3 months, 3 months of life, presents snuffles associated with the purulent discharge and the fissuring and excoriation of the vestibule and the upper lip. Late form occurs around the puberty. Gummatous lesions, corneal opacities, deafness and Hutchinson's teeth. So VDRL and biopsy, demonstration of Treponema pallidum. Dark ground emulation shows the spirochete. Treponema pallidum heme agglutination test and the fluorescent treponemal antibody test titrates are specific. What is the treatment? Treatment is the benzathine penicillin, 2.4 million units, intramuscular for 3 weeks. Total dosage is 7.2 million units. Alkaline nasal irrigation for the nasal crust. Yellow mercuric oxide ointment for the nasal vestibulitis, and the cosmetic surgery is required. What are the complications? The vestibular stenosis, the perforation, saddle nose, and secondary atrophic rhinitis. Now let us talk about the tuberculosis, which is very common in India. Well, the tuberculosis, the primary TB of nose, is rare. So the nasal involvement of the primary tuberculosis is rare. Secondary to pulmonary TB, it basically occurs. So the anterior part of the nasal septum and the anterior end of the inferior turbinates are the most common sites. So anteriorly, it affects the anterior part of the nose, like the interior end of the inferior turbinate and the nasal septum. Nodular infiltration leads to ulceration and to perforation in the cartilaginous parts. So further, it leads to septal perforation because of the nodular infiltration, which further lead to ulceration. Diagnosis is made by demonstration of the acid-fast bacilli on the special staining culture and biopsy. PCR, polymerase chain reaction, and BACTEC are the new modalities with the improved sensitivity for the Mycobacterium tuberculosis. Treatment is the anti-tubercular drugs. Now comes the lupus vulgaris. What is lupus vulgaris? Well, the low-grade tuberculosis infection affecting the nasal vestibule and the face skin. This is the lupus vulgaris, affecting the skin and the nasal vestibule. Well, what is the pathognomic? Well, the lesions are brown, gelatinous nodules, also known as the apple jelly nodule. This is the MCQ, that the apple jelly nodule seen in lupus vulgaris. Present as chronic vestibulitis, perforation in the cartilaginous portion is seen. So, and demonstration of the bacilli on the biopsy, and treatment is the anti-tubercular drugs. See, here you can see the apple jelly nodule, pathognomic of lupus vulgaris. Now comes the sinus granuloma. In a patient of tuberculosis, isolated sinus involvement can occur without any involvement of the nose. So earlier it is used to present as a diffuse soft tissue swelling and multiple discharging sinuses in the supraorbital region, secondary to the osteomyelitic involvement of the frontal bone. So CT and MRI demonstrate a soft tissue mass with or without any bony destruction. So how the diagnosis is made? Diagnosis is completely made on the biopsy, sinus granuloma. Now comes the leprosy. It is caused by the Mycobacterium leprae, commonly involved in the lepromatous type of leprosy. What is the MCQ? It commonly involved in the lepromatous type of leprosy. What is the site? Site is the anterior part of the septum and the inferior turbinate, as in tuberculosis. So what is the cause? Excessive nasal discharge with congestus mucosa followed by crusting and bleeding. Nodular lesions ulcerated to causing perforation. Sequel atrophic rhinitis, depression of the bridge of the nose, destruction of the anterior nasal spine, and the retraction of the columella. Here you can see how there is a depression of the nasal septum. Scraping of the nasal mucosa and the biopsy show lepra cells. So we will take the scraping of the nasal mucosa and the biopsy will show the lepra cells. This is for the diagnosis. Then the treatment is a dapsone plus rifampicin and isoniazid. Rifampicin is 600 mg on the first 2 days of each month, followed by before breakfast, and clofazimine 100 mg on alternate days, 3 times a week, and dapsone 100 mg daily. So direct intranasal administration of rifampicin reduces the bacterial load in the nose. 1 part betnovate and 2 parts anguntum prevents the external deformity. Reconstruction procedures in inactive state. Now comes the rhinosporidiosis. It is a chronic disease caused by the Rhinosporidium seaberry. In India, South India is the more commonly affected. Affects both humans and animals that share the same infected pond. Some consider this as a fungal entity, while some think of the protozoa or a fish parasite belonging to the DRIP clade, Dermatocystidium, rosette agent, Ichthyophonus, and the Sorospermum. Life cycle of the organism: the trophic stage, the sporangium's development, and the production of the endosphere. So what happens in the trophic stage? The endospore is oval of size 6 to 8 microns, containing the clear cytoplasm, a vesicular nucleus, a nucleolus, and a stint covering. Small endospores are formed by several divisions within a trophocyte. Sporangium development 200 to 250 micron in diameter, containing 12,000 to 16,000 endospores. Double-layered outer being chitinous and inner cellulose. Endospores mature within the sporangium, which develops a germinal pore through which the endospores are released. Production of the endospores start their life as a trophocyte and cell continues. Here we can see how this trophocyte convert into sporangium, and the rupture of the sporangium and then release of the endospores. What are the clinical feature? In nose presents as a leafy polypoidal mass, pink to purple, attached to septum or the lateral wall. This can be the MCQ. Vascular mass bleed on touch. Surface of the mass has a white dots presenting the sporangia. Mass may extend into the nasopharynx and hang behind the soft palate. Blood-thinning nasal discharge or a frank epistaxis may be the only presenting complaint. So what? Biopsy can be taken and a demonstration of the sporangia will be there. So treatment: complete excision with a diathermy knife and cautery of the base. Dopsone has been given some success. Reoccurrence is common in this disease. So this is the rhinosporidiosis. You can see. Now the aspergillosis, caused by the Aspergillus niger, Aspergillus fumigatus, and Aspergillus flavus. It's more commonly seen in the immunocompromised patient, presents as an acute or a subacute rhinitis or sinusitis. Maxillary sinus reveals a fungal ball having a semi-solid cheesy white or blackish material. Organism can be demonstrated on the special staining. Management includes surgical debridement and AMB. Repeated irrigation with a 1% gentian violet is also useful. Here you can see the aspergillosis, how it looks. Now comes the mucormycosis. It is a fungal infection of the nose and PNS which is fatal. Seen in immunocompromised patient, can spread to the orbit curvae from plate, meninges, and brain. Intracranial extinction. Arterial invasion occurs by the fungus which cause its fatality. So the fatality is because of its arterial invasion and intracranial extinction. Present is a black necrotic mass in the nasal cavity, eroding the septum and the hard palate. Special stents are used. AMB and the surgical debridement are the treatment of choice. This is the mucormycosis. You can see below is the normal left side. So this is the mucormycosis of the right ethmoid sinus and the middle turbinate. Here you can see. Now the sarcoidosis. It is a systemic condition also of unknown etiology. Seen in the 3rd and 5th decade of life. Male to female ratio is 1:2. It is a granuloma. Formation is due to the continuous antigenic stimulation, failure of the suppressor regulating mechanism, and abnormalities in the cytokine network. Interleukin 1 and interleukin 2 causes a T lymphocyte proliferation. Interleukin 8 acts as a monocyte chemotactic factor. Interferon gamma causes macrophage fusion to epithelioid cells, forming the granuloma. Here you can see how it looks. First is the nodular type, and second is the mutilating lesion with the extension of the nasal mucosa. Coronal CT showing the sclerosis and osteolysis of the nasal bone associated with soft tissue mass in the nasal sarcoid. Now the sarcoid granuloma contains the Schauman's bodies, the calcium and protein inclusion bodies, epithelioid cells, lymphocytes, fibroblasts, but without caseation. Multi-system disorder, but affects upper respiratory system more. So sarcoidosis affect the upper respiratory system more. In nose, mucosa is granular. So strawberry skin is there. There is a friable granuloma, nasal congestion, crusting, and blood-stained mucopurulent discharge. Perforation in the anterior part of the septum. The facial pain is there, and the anosmia is there. Adenoid enlargement can cause the OM and dyspnea and change in voice due to the thickening of the supraglottic larynx. Diagnosis: AC is often raised. ESR, S globulin, urine calcium are raised. Eosinophilia with a mild anemia, leukopenia, and thrombocytopenia is there. Plain X-ray of the nasal bone show punctate osteolysis. Biopsy of the nasal mucosa, chest X-ray, CT thorax, and perfusion studies with a bronchoalveolar lavage and gallium-67 scanning. CT scan nose and PNLs for the soft tissue changes along with the osteolysis. MRI brain for the CNS involvement. What is the treatment? Oral steroid, methotrexate, hydroxychloroquine given in systemic therapy. Intranasal drops or spray, glycerin drops with a nasal irrigation for a topical treatment of nose. Surgery usually contraindicated in this condition. What is Wagner's granulomatosis? Well, the granulomatous disease of the small to medium-sized vessels. This is the MCQ. What is the granulomatous? This is the granulomatous disease of the small or medium-sized vessels. Basically, what it involves the respiratory tract, the blood vessels, and the kidney. So, involvement of the respiratory tract, necrotizing vasculitis, and the necrotizing glomerulonephritis. So, what is the hallmark triad is the involvement of the lungs, the airway, the renal disease, airway, lung, and renal disease. Young adults affected commonly. Etiology, unknown etiology. Antibody reacts to the cytoplasm of the granulocytes. What are the clinical features? So in Wagner granulomatosis, you will get the epistaxis. Epistaxis, nasal obstruction, bloody crust, destruction of the septum, facial pain, progressive malaise, pyrexia, weight loss, and other oral symptoms like the hyperplastic granular lesion of the gingiva and the extensive ulcerative stomatitis. OME, facial nerve palsy, hearing loss. Idiopathic subglottic stenosis is rare. So what is the 1990 ACR criteria for the classification of Wagner's granulomatosis? Number of criteria. See, so criteria there should be presence of, for the classification purpose, a patient shall be said to have Wagner's granulomatosis if he or she has satisfied any two or more of these four criteria. Two or more. Associated with the sensitivity of 88.2% and specificity of 92%. So what are those criteria? Four criteria. Nasal or oral inflammation. So development of the painful or painless oral ulcers or purulent or bloody nasal discharge. First point. Then second is the abnormal chest X-ray. So the X-ray showing the presence of nodules or fixed infiltrates or cavities. Third, urinary sediment. So there should be microhematuria over 5 red blood cells per HPF or red cells cast in the urine sediment. Granulomatous inflammation on biopsy. Histologic changes showing the granulomatous inflammation within the wall of an artery or the extravascular area, artery or arteriole. So any two or three of this should be present for the criteria. So here we can see how it's affect the small and the medium sized blood vessels. Leading in the nose, it leads to bleeding. In lungs, it leads to bloody cough. In the kidneys, it leads to glomerulonephritis, muscular pains, fever, headache, weight loss. You will have the purpura, you will have the pain, arthritis, bloody stools, myocardial infection, hypertension affecting the heart, and stroke. So almost involving every system in the body. So what is the diagnosis? C. ANCA in 95% is there. CBC, ESR, CRP, serum urea and serum creatinine, SACE, renal function test, pulmonary function test, tissue biopsy in nose for the septum and turbinates, CT mucosal thickening with the bony destruction and new bone formation in sinus wall, MRI fat signal for the sclerotic sinus wall. So what is the treatment? Prednisolone 60 to 80 milligram per day with the cyclophosphamide 2 milligram per kilogram or azathioprine 200 milligram per day in acute diseases. So what are you going to give in the Wagner's? Prednisolone you are going to give. You are going to give the cyclophosphamide. Prednisolone is given with cyclophosphamide or azathioprine is given in acute diseases. Plasma exchange hemoglobin infusion with methotrexate and cyclosporin. Mycophenolate mofetil alternative to azathioprine. Alendronate sodium for the bone loss. 5 to 10 milligram per day prednisolone for maintenance. Cotrimoxazole for the secondary infection. Intranasal steroids, glycerin and douching. No augmentation rhinoplasty unless the disease is constant for some years. Now comes the Church-Strauss syndrome. What is this? Syndrome of systemic vasculitis and asthma. Small to medium sized blood vessels affected, same as in Wagner's. Eosinophil rich and granulomatous inflammation involving the respiratory tract and necrotizing vasculitis. Histologically, necrotizing giant cell vasculitis, interstitial granulomas and eosinophilic pulmonary infiltrates. What are the clinical features in the Church-Strauss? Bronchial asthma, nasal polyp, eosinophilia, systemic vasculitis, nasal crusting and septal perforation. Treatment is the oral steroids or medical and surgical treatment of the polyp. Now comes the eosinophilic granuloma. In a clonal proliferation of the Langerhans cells associated with the heterogeneous inflammatory infiltrate of eosinophils, histocytes, lymphocytes, plasma cells and neutrophils. So what having in the eosinophilic granuloma? It is a clonal proliferation of the Langerhans cells associated with the heterogeneous inflammatory infiltrate of the eosinophils, histocytes, lymphocytes, plasma cells and neutrophils. Considered as a neoplastic condition, also known as Langerhans cell histiocytosis and Langerhans granulomatosis. So, eosinophilic granuloma is also known as histiocytosis, Langerhans cell histiocytosis and Langerhans granulomatosis. Commonly seen in the first 3 decades of life and male is to female ratio is 2:1. Clinical feature is the painful swelling of the involved bone, most commonly skull, cervical lymphadenopathy, toothache, gum ulceration, loose teeth, temporal bone involvement causing acute mastoiditis, punched out lesion on radiology, and radiolucent area around the teeth in jaws is the MCQ. Skull lesions show beveled margins due to the angulated destruction of the cortical bone, MCQ. Macroscopically, soft yellow, red, brown lesions are seen. Microscopically, eosinophilic charcot-laden crystals indicative of active eosinophilic inflammation and intense osteoclastic activity is seen. Here you can see. Treatment: some regress spontaneously, unifocal disease type 2, radiotherapy with curative excision, type 2 etoposide with steroid for 12 months, bone marrow transplant and alpha interferon, and type 2 disease are compromises of osseous lesions with a hepatosplenomegaly, lymphadenopathy and skin lesions. Now comes the giant cell granuloma. What is giant cell granuloma? It is a benign aggregate of giant cells in a fibrovascular stroma. This condition refers as a giant cells reparative granuloma or a giant cells reaction of bone. In 1953, Jeff described in JAWS. Seen in children and young adults, not multinucleated. So it shows bilateral symmetrical involvement of the jaw in cherubism. Now, central giant cell granuloma, a bluish purple mass is present on the anterior alveolar ridge in a 4-year-old boy. Here you can see coronal CT scan of the upper and the lower jaw showing a typical appearance of the cherubism. What is the clinical feature? Pain and swelling of the affected bone, diplopia, frontal headache, hearing loss, vertigo, tinnitus. Male is to female ratio is 1:2. Maxilla and the mandible most common affected, followed by sphenoid and the temporal bone. Microscopically, granuloma has a cellular fibroblastic stroma containing the aggregate of the joint cells. Serum calcium and the ALP elevated helps in distinguishing from the brown tumor. An excision is a choice of treatment. Now comes the cholesterol granuloma. Hemorrhage or trauma causes granulomatous reaction to the cholesterol crystals, causing their precipitation in the tissue. Duration of symptom 3 years on an average. Third to sixth decade of life, it is mostly present. Male affected more. The expansion of the maxilla or the frontal sinus, cosmetically deformed, and displacement of the globe. Cystic-like expansion of the bone or the sinuses, which is opaque on CT and is non-enhancing. Microscopically, foreign body-like giant cells surrounding the clefts created by the cholesterol crystals. Complete surgical excisions are treatment of choice. Now comes the granulomatous neoplasia, the midline destructive granuloma. T natural killer cells lymphoma causes classical destruction of the midface. McBitch first told about the disease. Stewart described the histology. In the past, death occurs due to the incurrent infection of lymphoma. First to 9 decade, medium being the 5th decade, and males affected more. Here you can see. Now there are the different stages: the prodromal stage, the period of necrosis, and the terminal stage. So in the prodromal stage, it lasts for many years. Nasal obstruction and rhinology are the major complaints. Then the period of necrosis, where the pulmonary discharge, crusting, and a tissue loss occurs. Destruction of the nasal framework, palate, upper lip, orbit, skull base is associated secondary to infection. The terminal stage, a gross mutilation of the face and hemorrhage and exhaustion leads to death, associated with the metastasis. Biopsies show atypical cell infiltrates. So, immunohistochemistry using a panel of monoclonal antibodies against the T cell differentiation antigen, granulomas and the giant cells are not present. Thrombosis and necrosis is common and associated with the Epstein-Barr virus and helps in the early prognosis. So treatment is a low dose radiotherapy, radical full dose of radiotherapy 55 gauss or more, covering nose, sinuses and palate, in high grade chemotherapy to be given. Thank you.